Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. For our breakout session, let us unravel the mysteries of interpreting thyroid function tests, which will be discussed by Dr. Erick S. Mendoza, a consultant in the University of Santo Tomas Hospital and St. Luke's Medical Center, Quezon City, and is currently a faculty member of the University of Santo Tomas Faculty of Medicine and Surgery. He is the current training officer of the Department of Medicine at Tondo Medical Center and is a board of director at the Philippine Thyroid Association. This session will be moderated by Dr. Celeste Ong Ramos, the Fellowship Training Officer at St. Luke's Medical Center, Quezon City, and the Section Head of Endocrinology, Diabetes and Metabolism of the Los Santos Medical Center.
Welcome everyone. This breakout session is about thyroid function test interpretation. As an internist, I am sure it is very common that you request a set of thyroid function tests, and once the result comes back to you, half of the time there is discordant reading. What is more interesting is that most of the results does not reflect the clinical condition of the patient. Unlike in fasting blood glucose, wherein your interpretation is limited to normal, prediabetes, or diabetes, in thyroid function test, a discordant result may mean ruling out several diagnoses and possibly repeating the discordant result. But before we take a deep dive in this pool of thyroid function abnormalities, let me greet everyone a blessed 2021. Our topic outline is simple. I will present the key points in thyroid function testing from basic principles in physiology and biochemistry. We will review the negative feedback mechanism and how it affects the TSH and thyroid hormone levels. We will take a look on the available assays locally and cite the probable potential errors innate to biochemistry, and we will review the main group of thyroid diseases. The clinical part is divided into three: the commonly encountered thyroid diseases, the subclinical thyroid conditions, and the discordant TFT results. The illustration is very familiar with you. This is the hypothalamic pituitary thyroid axis. The hypothalamus produces the tripeptide, TRH, which binds to the thyrotropes of the pituitary gland. The pituitary gland will produce and secrete a peptide hormone called TSH. TSH will bind to the TSH receptor in the thyroid gland. TSH is trophic to the thyroid tissue, and at the same time, it promotes thyroid hormone production. T4 is either activated to T3 or to inactive RT3, depending on the metabolic need and adaptation of the body. Everything is regulated in a very intricate mechanism. The secreted thyroid hormones FT4 and FT3 provides a negative feedback, inhibiting the release of both TRH and TSH upstream of the axis. TSH, TP4, or total T4, total T3, FT4, and FT3 axis are available locally. Later on, we will discuss the difference between them. TRH and RT4, or RT3 rather, are only available for research. Most of the time, you cannot memorize the normal values for FT4 and FT3 because of different laboratory references and their units of reporting. However, it pays to have an idea on what is a normal TSH because for two reasons, the assay is more uniform and it is the single most important test in the screening for thyroid diseases. And usually, it is between 0.4 to 4.2 international units per ml. It is also helpful that we imagine that the negative feedback mechanism is working like a seesaw. On your right, are the T4 and T3 levels. For the sake of our discussion, we will take T4 and T3 collectively as the thyroid hormones, capable of exerting negative feedback with regards to TSH secretion. On your left side is your TSH, of course. Take note that the fulcrum of the seesaw is not in the center. It is closer to the T4 and T3 rather than TSH. Imagining it this way will give us some idea that the magnitude change on each side is never equal. A small change in T4 or T3 will result to a reciprocally large change in TSH. That's not in absolute units, of course, but in relative incremental change. In physiology, hormonal secretions occur in pulses. Therefore, blood levels change in the time continuum. However, our body is able to defend homeostasis by maintaining these levels within the normal range as represented by the blue bar in our figure. If T4 and T3 decrease to low normal levels, TSH secretion reciprocally changes in a larger and opposite direction, as you can see on the left side of the figure or of the screen. And at once, the TSH is in command of the thyroid gland, ensuring that more thyroid hormone will be secreted, bringing back to the balance. The opposite is true if T4 and T3 increases. TSH is suppressed in a larger magnitude, but still within normal. Unless TSH is outside the blue bar, we will not consider any thyroid dysfunction. The proper term to use when I say that there is a larger magnitude change of TSH in opposite direction is the negative log linear curve of T4 or FT4 in relation to the TSH. The x-axis represented by FT4 is independent variable in this curve. FT4 is the best reference because 100% of T4 comes from the thyroid, and FT4 is the active portion of the total T4. The y-axis is represented by your TSH. Here we can appreciate that small change in FT4 can easily swing TSH outside its normal range in the opposite direction. Of course, this is provided that the patient is in steady state, meaning there are no conditions like critical illness or no medications given affecting TSH secretion or thyroid hormone binding. Recently, like your steroid or your oral contraceptive pills. Another assumption is that there should be no hypothalamic or pituitary disease that can prevent appropriate TSH response. In other words, this negative log linear relationship excludes secondary or tertiary thyroid pathology. Throughout the decades, there have been important changes on the way TSH is determined. Before 1990, laboratory centers used first and second generation TSH assays. What does this mean? Look at the table on your left screen. For a first generation assay, its lowest detectable TSH is your 1. For second generation assay, its lowest detectable assay is zero point 0.1. Most of the available assay now in most tertiary centers is the third generation assay with lowest detectable level of zero point 0.01. It is good to know that there is also fourth generation TSH assay, but for most cases, it does not provide any more additional advantage than the third generation assay. Consider the two cases on the right. For the first case, a 26-year-old male presented with hypothyroidism 3 months after radioactive iodine therapy. Laboratory results were as follows. FT4 from the three assays are all low. However, the TSH was also determined using the three different assays. As you can see, all of the assays were able to detect appropriately high TSH in the setting of his condition, which is hypothyroidism after RAI therapy. This is because all TSH assays, as long as properly done, can detect TSH levels as it increases in the spectrum of hypothyroidism severity. So there will be no misdiagnosis in the first case. But take a look at one case, a 21-year-old female presenting with thyrotoxic symptoms since 4 months ago. Laboratory was done thrice using the different assays. FT4 levels were high. However, there are discordance or discrepancy in the TSH results. The first generation assay, it cannot detect the real suppressed TSH, therefore causing the discordance, which may lead to possible misdiagnosis. The separation assay may detect the suppressed TSH, but there is little margin of error from zero point 0.1 to zero point 0.4, which is the lowest limit of normal. Therefore, it is imperative that you are aware of the TSH assay generation when you interpret the results, particularly dealing with thyrotoxicosis or hyperthyroidism. Generation assay or fourth generation assay can assure diagnosis, while the first and second generation assays may lead to potential error in interpretation. In the local setting, you may encounter tests indicating IRMA, which means immunoradiometric assay, or ECLIA, which means electrochemiluminescence assay. The difference lies primarily on the technique. For IRMA, radio tracer like iodine 125 is used, while ECLIA uses electromagnetic and light reaction in quantifying the TSH. Minor differences are from specimen preparation and stability. Potential sources of error, although rare, can possibly exist, like patient antibodies interfering with the binding. Important to note is that biotin supplement more than 5 milligram per day can interfere with ECLIA. Let us look at ECLIA. For example, the patient's serum is incubated with two antibodies, ruthenium labeled anti-TSH and biotinylated anti-TSH. Both these antibodies will sandwich your TSH. The biotinylated end will bind to streptavidin beads. Once bound, electrode will be applied, causing light to be emitted by the ruthenium end. The intensity of light is proportional to the concentration of TSH as detected by your spectrophotometer. Also, T4 and T3 are determined through somewhat similar assays. The principles presented are the main reasons why TSH is the single important component of the thyroid function testing. Why is thyroid function test best assessed by TSH level? Because there's now available third and fourth generation assays, which is more sensitive and specific. TSH has longer half-life, therefore there are less fluctuations. And you can appreciate the negative log linear response to T4 changes, which leads to a more pronounced increment or decrement in your TSH depending on the change in your FT4. Therefore, in a discordant thyroid function test result, TSH is likely the more reliable and non-discordant component. Again, the assumptions are as follows. You are using a third generation TSH assay. There is no hypothalamic or pituitary dysfunction. There is no interfering condition such as medication or illness. It is also important for internists, especially when dealing with patients admitted in the hospital, to recognize two things that can acutely disturb TSH reliability. And these are critical illness and starvation. This is mediated by your cytokines and interleukins, and they can suppress your TSH. There are also medications such as steroid and pressors, which can suppress TSH. Recombinant leptin, although not available, can increase your TSH. However, the suppression of TSH using the common medications are usually just between 0.08 to zero point 0.4, which is higher than what is usually found in patients with thyrotoxicosis or hyperthyroidism. Take note of this table. These are some of the common drugs that can acutely decrease TSH, and I'm sure you're familiar with most of them. Dopamine, dobutamine, octreotide, steroid prednisone, equivalent to 20 milligram per day, your SSRIs, drugs that can increase your TSH, even transiently, are your dopamine antagonists like metoclopramide, use of opioids, amphetamines, and haloperidol. This is how the thyroid hormone is synthesized. Iodine is first transported into the thyroid follicular cells using your sodium iodide importer. Then iodine is oxidized to iodide. Iodide is then organified to form your monoiodotyrosine and diiodotyrosine. And these are bound to your thyroglobulin, represented by the purple figure. Your mono and diiodotyrosine are coupled to form your T3 and T4. The oxidation, organification, and coupling are all performed by your TPO. T4 and T3 are released while thyroglobulin is degraded and stays inside the thyroid follicle. Please remember that the thyroid gland secretes T4 more than T3. It is easy to remember that more than or about 90% are T4 and a smaller proportion of about 10 to 20% is T3. This will make it easier for us to understand the next slide. What is the difference between T4 and T3? As I have mentioned from the previous slide, about 80 to 90% of thyroid gland secretion is T4. This is about 8 microgram per deciliter. Only less than 1 microgram per deciliter is T3. Out of these absolute concentrations, most of the hormones are bound to proteins. But with regards to proportion, more T3 in percentage are free. With regards to absolute concentration, since 90% is T4, there is more bound and more free T4 compared to its counterpart in the T3. The serum half-life of T4 is longer. It's 7 days versus 3 days half-life of your T3. It is also helpful to view the T3 as an active hormone. Since T4 is almost always converted intracellularly to T3 before it binds to the receptor. Likewise, the potency of T4 is only 30% that of T3. Another illustration I want to show you is the conversion of your T4 to T3. 80% of T3 is from T4 conversion. Only 20% directly comes from the thyroid. Another product of T4 is your reverse T3. In conditions such as critical illness and prolonged starvation, the body adapts by slowing metabolism and diverting T4 to your inactive reverse T3. Take note that in hypothyroidism, there is enhanced conversion of T4 to T3. T4 decreases early, but conversion to T3 is preserved unless hypothyroidism becomes moderate to severe. Therefore, T3 is not useful to diagnose early hypothyroidism. We don't request T3 if our strong clinical suspicion is geared towards hypothyroidism. For hyperthyroidism, there is increased secretion of both T4 and T3. However, T3, which is normally 10% or less of thyroid gland output, increases disproportionately than T4. It is now more than 20% of circulating T3 coming from the thyroid. There's also what we call the T3 over T4 ratio. And we use particular units such as nanogram for T3 and microgram for total T4. If it is more than 20, it is a characteristic of Graves' disease, but we rarely use this parameter now. As mentioned earlier, in sick thyroid syndrome or non-thyroidal illness, characteristic of critical illness, much of T4 is converted to reverse T3. Therefore, low T3 is an early feature of non-thyroidal illness. So when is serum total T3 and free T3 clinically useful? So as I have mentioned, for hypothyroidism, there is no utility for your total T3 or FT3. But there are 3 conditions or group of conditions in which T3 might be useful or helpful. First is the diagnosis of your primary hyperthyroidism, especially Graves' disease. It's an early sign of Graves' hyperthyroidism. Also, early response to anti-thyroid drug treatment in Graves' disease. T3 thyrotoxicosis, in which T4 is still normal, TSH is suppressed, you need to check if T3 is elevated before mislabeling the patient as subclinical hyperthyroidism. And lastly, early recurrence of hyperthyroidism after cessation of anti-thyroid drugs. Sometimes T3 rises earlier than your T4. Again, for your non-thyroidal illness or CQ thyroid syndrome, oftentimes low T3 is the first presentation. There are also complex hyperthyroidism or thyrotoxic cases. when you see a high or paradoxically normal T3 in the setting of low TSH, you might want to think of a hyperthyroidism in non-thyroidal illness patient with suppressed TSH. It also may indicate amiodarone-induced hyperthyroidism. High T3 and high normal TSH may indicate a TSH secreting adenoma or a thyroid hormone resistance syndrome. Again, because these are complex conditions, these are not the run-of-the-mill cases that we want you to especially understand. What is the difference between total and free T4 and T3? At this point in time, it is important to tell the difference. By doing so, we can minimize the cost of our request and lessen discordant results. Total T4 and total T3 represents the sum of the bound and free ones. As mentioned earlier, the free fraction is a very, very small portion of the total hormone. For T4, the free T4 is only 0.03%, and for T3, the FT3 is relatively higher at 0.3%. Most of the T4 and T3 are bound to your thyroxine binding globulin, followed by your albumin. What is the implication of these? The bound hormones are subject to changes in binding proteins, particularly the thyroxine binding globulin. Conditions that will increase TBG, such as your estrogen, will increase bound hormonal fraction in order to defend or maintain the same free fraction. Hence, the reading of total T4 in the case of T4 will increase. The opposite is true for factors that will decrease TBG, such as your androgen, and factors that will decrease your albumin, such as nephrotic syndrome and hepatic cirrhosis. The free thyroid hormone in this illustration of the FT4 or the FT4 is the metabolically active portion or fraction. It is biochemically active, and hence physiologic responses are geared towards maintaining this constant fraction. It is not affected by binding proteins, at least in the steady state. For your information, these are the drugs that can decrease and increase both total and free thyroid hormone production. Drugs that decrease thyroid hormone production are, of course, your antithyroid, iodine, lithium, tyrosine kinase inhibitors, and interleukins. Drugs that increase thyroid hormone production are your iodine and iodide containing drugs, and also your immune modulating drugs such as your alemtuzumab. On the other hand, there are some drugs that can affect the free hormone at least in short or medium term until the new steady state is achieved. A good example is estrogen, for example, which is in the oral contraceptive pill. In a woman with a whole thyroid gland removed and on levothyroxine replacement therapy, TSH and FT4 may be normal after titration. But when she takes OCP or oral contraceptive medication, her thyroxine binding globulin or TBG will increase. And more FT4 TBG, there will increase FT4. But since there is no thyroid gland to defend the steady state and return back the FT4 level to normal, subsequent determination will reveal a low or inadequately replaced FT4 unless adjusted. Remember, in a patient with intact thyroid gland, most of the changes brought about by these drugs are often transient and negligible. But for pharmacologically replaced individuals, drugs such as your estrogen, your inhibitors of absorption, those that increase lipothyroxine metabolism, such as rifampicin, phenytoin, barbiturates, imatinib, can decrease your serum free thyroid hormone. And drugs like salicylates, dilantin, and heparin can increase your serum free thyroid hormone. Again, this is a negative feedback at work using our CISO illustration. This is a euthyroid condition. To reorient you, T4 and T3 are on the left side and your TSH is on the right side. The fulcrum is closer to T4 and T3. Still in the euthyroid territory, physiologic disruptions may lower T4 or T3 transiently. TSH will increase to upper limit of normal and the normalcy is defended. In its mildest form, T4 may still be normal, but too low for pituitary gland to take or bear, the TSH swings up, exceeding the upper normal level. This condition is what we call your subclinical hypothyroidism. In its overt or clinical form, T4 becomes too low and TSH becomes very high, often above 10. This condition is called overt hypothyroidism. Again, assumption is that your hypothalamus and pituitary gland are intact. On the other hand, euthyroidism can be disturbed to the other end. Still in the euthyroid territory, physiologic disruptions may increase T4 or T3 transiently. TSH will decrease to lower limit of normal until normalcy is defended. In its mildest form, T4 may still be normal but may be too high for the pituitary gland to take or bear. The TSH goes down below your lower limit of normal. This condition is what we call the subclinical hyperthyroidism. In its overt or clinical form, T4 becomes too high and TSH becomes suppressed, often below zero point 0.1. This condition is called overt hyperthyroidism. Again, the assumption is that the hypothalamus and the pituitary are intact. As internists, the cardinal rule still applies. We look at the patient more than the thyroid function test results. We can afford to repeat the thyroid function test if necessary, but we cannot afford to offer a wrong diagnosis and therefore a wrong management plan. Here are the things to factor in before and after the result has come out. So let us take into consideration these factors. Whether the patient has hyperthyroid or hypothyroid symptoms, which includes weight change, temperature intolerance, bowel changes. Medications affecting thyroid or and its compliance to those medications, such as levothyroxine, oral contraceptive pills, the targeted therapies I mentioned earlier. We also would want to ask whether the patient underwent thyroid surgery, radioactive iodine therapy, or even external beam radiotherapy for other types of head and neck malignancy. Whether the patient has history of cancer and autoimmunity, because autoimmune thyroid dysfunction is also commonly associated with other autoimmune polyendocrinopathy and multiple endocrine tumors. We want to know if there is setting for hypothalamic pituitary dysfunction, whether the patient is in a critical condition or recently recovering from a critical condition. Also, if ICU medications are given, such as your steroid and dopamine and other pressors. Also, we will want to rule out cellular or pituitary tumors that can give you secondary hypothyroidism or thyroid dysfunction. The other contributing factors that are important are the age of the patient, the fertility desire of reproductive age female, and the presence of thyroid antibodies. For the physical exam, we will concentrate or focus on the goiter, the eye signs, the CD, and the neurologic signs. We want to know if there's diffuse or nodular goiter, heart failure signs, orbitopathy, cognition of the patient, and reflexes. Of course, I always include to be familiar with the assay technique that was used and its reliability. If there are discordant results, or if there are results that does not correlate clinically with the patient, you might want to consult the lab technician or the lab specialist on what type of assay was used. The generation of the assay, whether it's IRMA or CLIA, and other potential error which may be innate to the patient or to the lab assay that was used. In this slide, done by the Philippine Thyroid Diseases Study in 2012, the overall prevalence of thyroid disease in the country is actually 8.53%. Although only 1 represents overthyroid disorders, or just 1%, a good proportion has subclinical hyperthyroidism and subclinical hypothyroidism. Considering the sum prevalence of 8.53%, it seems that thyroid disorders are even more prevalent than diabetes in the Philippines. That's why, as internists, we should be familiar with them, at least the most common ones. One of the most important concepts in thyroidology is to be able to differentiate thyrotoxicosis from hyperthyroidism. Thyrotoxicosis is any state of thyroid hormone excess, regardless of source, endogenous or exogenous, and regardless of the process, tumor, leakage, or genetic mutation. On the other hand, hyperthyroidism is just a subset of thyrotoxic conditions wherein there is increased thyroid hormone production from the gland itself, not from leakage, not from any extrathyroidal source. Therefore, remember these 2 points. All causes of hyperthyroidism may lead to thyrotoxicosis, but not all thyrotoxicosis results from hyperthyroidism. Second, a suppressed TSH and high FT4 and or FT3 is at most representative of thyrotoxicosis unless a hyperthyroid cause can be ascertained. 80% of hyperthyroidism is caused by Graves' disease. This is, of course, from the thyroid receptor stimulating antibody or the TRABs. This is followed by your toxic adenoma and multinodular toxic goiter. These are the big three, the most common causes of primary hyperthyroidism. Other important causes are trophoblastic diseases and TSH secreting adenoma. Thyrotoxicosis without hyperthyroidism may be due to exogenous but extrathyroidal overproduction of thyroid hormone. For example, your struma ovarii or distant functioning thyroid metastasis. Second, it can be from leakage from follicles, especially your subacute thyroiditis, presenting with thyrotoxic phase. Important to rule out is overreplacement, iatrogenic, or intentional intake of thyroid hormone or iodine containing products. For hypothyroidism, excluding surgery and radioactive iodine therapy, the most common cause of primary thyroid hypofunction is Hashimoto's disease, or chronic autoimmune destruction of the thyroid gland. But again, history will include prior surgery, radioactive iodine, or even external beam radiotherapy for non-thyroid head and neck malignancy to rule out these potential causes. Severe illness can lead to acquired central hypothyroidism reminiscent of the severe non-thyroidal illness or CQ thyroid syndrome. Pituitary adenomas and other cellular tumors are the most common cause of secondary or tertiary hypothyroidism. Following postpartum thyroiditis or subacute thyroiditis, a proportion of patients will proceed to the hypothyroid phase. Lastly, in the event of target therapies in oncology, tyrosine kinase inhibitors and monoclonal antibodies can potentially cause transient or permanent thyroid destruction. For the clinical part, let us begin with our cases. If you see slides with the pulse sign just below, just like in this slide, our dear medical residents may deploy poll questions on which you are asked to vote or choose an answer. If poll questions are not deployed due to technical reasons, please type the letter of your answer on the chat box, so that late in the live session, we can choose which important points we would like to emphasize more. We super highly encourage your active and giganormous participation. Let's start with the first case. For this case, this is a 28-year-old female who presented with weight gain, cold intolerance, and constipation. She was recently diagnosed of type 1 diabetes and she is on insulin. There was no previous thyroid surgery or radioactive iodine therapy. On physical exam, she has diffuse goiter and vitiligo. For this set of questions, which set of thyroid function tests would you like to request? Letter A, TSH. Letter B, TSH and FT4. Letter C, TSH and FT3. And letter D, TSH, FT4, and FT3. Kindly key in your answers. The cost-effective choice is choice letter B. In the diagnosis of patients suspected of clinical hypothyroidism, TSH and FT4 are the recommended tests. As mentioned earlier, there is enhanced conversion of T4 to T3 in hypothyroidism. Therefore, the first pool to be depleted is T4, and T3 remains normal until the latter part of the process, or more severe form of the disease ensues. Anti-TPO antibody is the hallmark of Hashimoto disease. Almost all patients with chronic autoimmune thyroiditis or Hashimoto's disease has this antibody. It is said that this is a complement-fixing antibody, paving way for the process of thyroid gland destruction. Aside from supporting the diagnosis, there is no additional utility for requesting anti-TPO unless other diagnosis is entertained, or anti-TPO will help in the treatment decision for more complex cases like subclinical hypothyroidism. It is not requested anymore considering its cost and limited availability. Let's go to the second case. This is a 48-year-old female who presented with weight gain, joint pains, and hair loss. She underwent total thyroidectomy 4 months ago. Pathology result showed colloid adenomatous goiter. She was given levothyroxine 25 microgram daily. Her present weight is 62 kilograms. And this is the result of her thyroid function test. TSH is elevated at 88 and your FT4 is low at 0.24. Of course, we will interpret this as hypothyroidism. And because we got the right history, we know that this is because from her previous surgery. As an astute internist, should not miss the history of prior thyroid surgery or radioactive iodine therapy to avoid other unnecessary tests. This will also lower the threshold for multiple repeat testing and treatment decision. For our poll question, what is the probable cause of abnormal thyroid function test? Is it letter A, non-compliance, letter B, poor levothyroxine absorption, letter C, inadequate levothyroxine dose, or letter D, is it all or any of the above? The answer is either all of the above or any of the above. Combination of any two or more of these conditions might lead to the hypothyroidism of the patient. Levothyroxine has relatively wide therapeutic index, but it is easily affected by exogenous factors. Non-compliance is still the most common cause of persistent hypothyroidism or subclinical hypothyroidism. One should always review the manner of thyroid hormone intake. It should be taken on an empty stomach to improve gastrointestinal absorption. Trace minerals like calcium, iron, and others should not be taken with it. In this patient who underwent total thyroidectomy, the levothyroxine requirement is more or less 1.6 microgram per kilogram per day. In this 62 kilogram patient, the dose is around 100 microgram per day. Still with this case, the dose of levothyroxine was adjusted to 100 microgram daily. With proper compliance, the patient returned after 2 weeks. She had her repeat test done ahead of instruction because she was instructed to repeat it 6 weeks after the adjustment of levothyroxine. So the results showed improvement of TSH but still high, and FT4 returned now to normal. Look at the repeat test ahead of the instructed 6 weeks. The FT4 has already improved to low normal value, but the TSH has not yet corrected. And this is because TSH takes longer time to adapt to a new steady state. It takes around 4 to 6 half-lives, or in the case of your T4, 4 to 6 weeks to achieve steady state, which is reflected by its feedback on the serum TSH. Therefore, do not adjust until the steady state is achieved. Be careful not to label this as inadequately replaced patient or a case of a subclinical primary hypothyroidism, knowing that the patient underwent surgery prior. The dose of levothyroxine is based on the degree of hypothyroidism. Patients who underwent total thyroidectomy will need a full dose of 1.6 microgram per kilogram body weight while those with partial thyroidectomy may need lower dose or not at all. Patients who underwent radioactive iodine therapy may not need it immediately, unlike those who underwent surgery. For a mild degree of hypothyroidism or elderly patients, initial dose of 25 microgram per day is a sound option. Titration is done every 4 to 6 weeks until optimal TSH target is achieved. Remember that some of patients may deviate from mid to normal target. For example, thyroid cancer patients may warrant lower TSH, which means higher levothyroxine dose, while on the other hand, elderly patients may require higher TSH, therefore lower dosing of levothyroxine. So for our next case, this is a 22-year-old male who presented with proximal muscle weakness, inability to stop after alcohol binge a night ago. There was no goiter or orbitopathy. Upon admission, serum potassium was low, 2.4 milliequivalent per liter. He has no intake of diet or herbal pill. For our question, which set of thyroid function tests would you request? Letter A, TSH. Letter B, TSH and FT4. Letter C, TSH, FT3. Or letter D, TSH, FT4, and FT3. In this patient, you are certainly entertaining thyrotoxic symptoms. Thyrotoxicosis is one of the conditions you want to include FT3 for the following reasons. A few subset of thyrotoxicosis will present with T3 toxicosis and a normal T4. Second, the elevation of T3 may give a clue as on the pathology. Relatively higher T3 in comparison to T4 in hyperthyroidism exists, especially in Graves' disease, and relatively lower in leakage thyroiditis because of flooding of the FT4 in the circulation more than the T3. You are very fortunate if you see pathognomonic signs of Graves' disease like orbitopathy, dermopathy, or acropathy. But we have to understand that only minority of patients will present with such. Even goiter is only present in about 50% of patients presenting as Graves' disease, while the other pathognomonic signs such as orbitopathy is only present in 30%, dermopathy in 0.5%, and the very rare acropathy in about 0.1%. TSH receptor antibody is positive in more than 95%, but most of the time it is not available in some settings. So even the absence of the telltale signs of Graves' disease, it should always be a consideration in the evaluation of thyrotoxicosis. Graves' disease represents 80% of all the causes of thyrotoxicosis. Thyrotoxic phase of thyroiditis is a differential in mildly enlarged thyroid gland. 96% of thyrotoxic periodic paralysis, just like in this male Asian patient, is associated with Graves' disease. TPP, as I have said, is more common among Asian males, including Filipinos. When entertaining other causes of thyrotoxicosis, thyroid uptake and/or TSH receptor antibody may be helpful. For our next case, this is a 25-year-old female who presents with palpitations, excessive sweating, and orbitopathy since 6 months ago. She has diffusely enlarged thyroid gland and proptosis. Heart rate is at 120 beats per minute, and there is hyperreflexia on all extremities. TSH is 0.01, and FT4 and FT3 are high. Correlating with these clinical findings, what is the most likely diagnosis? Letter A, Graves' disease. Letter B, toxic adenoma. Letter C, subacute thyroiditis. Or letter D, chronic or Hashimoto's thyroiditis. Of course, our interpretation of this thyroid function test is thyrotoxicosis. But because of the clinical signs of Graves' disease that is the most likely diagnosis. There are certain instances when you can make a diagnosis of Graves' disease on clinical grounds. Number one, when there are pathognomonic signs of Graves' disease, such as your Graves' ophthalmopathy. When the TSH receptor antibody is unequivocally elevated. Number three, when thyrotoxicosis has been present for more than 3 months, in which thyroiditis is ruled out, and other differentials such as hyperfunctioning nodule is also ruled out. TSH receptor antibody is the hallmark of Graves' disease. Almost all patients with Graves' disease has detectable TSH receptor antibody. Those who are negative are the subsets who may harbor thyroid blocking antibody or neutral TSH receptor antibody. And these are not detected in our routine assay. So maybe the small 5% who have negativity in the test for TSH receptor antibody harbor a different subtype of antibody, and thus they are labeled negative for this TRAB. Take note that even patients who underwent surgery or radioactive iodine may still have persistent TSH receptor antibody. This is the paradox why a post-thyroidectomy or post-RAI hypothyroid mother can give birth to a baby with neonatal thyrotoxicosis. For our next case, this is a 48-year-old female presenting with neck mass. She has palpitations and weight loss. On physical exam, there is non-tender, poorly delineated mass on the right of her neck. There was no ophthalmopathy either. This is the thyroid function test result. A low TSH of 0.12, FT4 and FT3 are elevated. Of course, our interpretation is thyrotoxicosis. At the same time, we can expand this interpretation when we correlate clinically to a nodular toxic goiter. What is the diagnosis of this patient? Is it A, Graves' disease with nodule? Letter B, toxic adenoma? Letter C, multinodular toxic goiter? Or letter D, any of the above could be a possible diagnosis. Nodular toxic goiter is an umbrella term for 3 causes of primary hyperthyroidism. Any of the 3 can be a cause. For solitary nodules more than 3 centimeters, consider toxic adenoma. However, Graves' disease with cold or hypofunctioning nodule can also complicate the differentials. There are 2 modalities that will help us narrow our differentials or even clinch the diagnosis. In this particular patient, the primary care physician initially requested for an ultrasound after seeing the initial thyroid function test. And the ultrasound showed solid nodule on the right thyroid gland measuring 3.8 by 2.4 centimeters. And you, the internist, decided to pursue a thyroid uptake and scan. These procedures uses low-dose radioactive labeled iodine, iodine 123 or iodine 131, or in some centers, they prefer the use of technetium systemib. Your thyroid uptake is a quantitative test that aims to evaluate the cause of thyrotoxicosis, meaning it will tell you whether the pathology is hyperthyroidism or whether from leakage thyroiditis. While your thyroid scan is a qualitative test which evaluates the thyroid gland nodule activity. Looking on the lower left of your screen, you can see that this image represents a result from a thyroid scan, while your thyroid uptake is reported as number in percentage. For our patient presented with a high 4-hour uptake and also a high 24-hour uptake if you compare it on the normal values on the right side of the screen. Also, the thyroid scan showed hot nodule on the right lobe, wherein there is increased uptake on this hot nodule compared to the rest of the gland. For a normal thyroid, there should be normal-sized thyroid with even spread of radioactive tracer. In our patient, if thyroiditis is still entertained, for example, the thyrotoxicosis has been present in less than 4 to 6 weeks, thyroid uptake may still be warranted. But if the patient has been presenting signs of thyrotoxicosis outside the expected resolution of the thyrotoxic phase in your thyroiditis, only a thyroid scan may be necessary. For the sake of discussion, our patient underwent both of these tests. In this next slide, you can see that there are different results when you subject a patient to a thyroid scan. As I have mentioned, a thyroid scan is a qualitative study, so it shows you the image of the uptake of the thyroid gland and its pathology. A normal thyroid, as shown in the upper right image, will show you a homogeneous spread of activity in the thyroid. While thyroiditis in your upper right corner shows that there's a low uptake and homogeneously low activity. The other conditions will present with increased uptake. This is most commonly exemplified by your Graves' disease, which will often present with homogeneously increased uptake, but sometimes they can also have concurrent nodule, just like the one in your lower left corner. Our patient, based on the result, has right thyroid gland nodule, and the increased uptake in this nodule, hot nodule, is most likely a toxic adenoma. But bear in mind that before seeing the result of a thyroid scan and thyroid uptake, the results may be any of the three in the lower row. It can be a Graves' disease with nodule, a toxic adenoma, or a multinodular toxic goiter with a prominent nodule on the right lobe. And because we did a thyroid scan, we are able to clinch the diagnosis of toxic adenoma. Toxic adenoma will present with hot nodule. This is a well-defined area of increased radiotracer activity, and the other areas of the glands are suppressed. Meanwhile, for more adult patients or elderly patients, the more common one is your multinodular toxic goiter, and it may manifest as combination of warm and cold nodules. For our next case, this is an 18-year-old female who presents with palpitations. 10 days ago, the patient had sore throat and low-grade fever that resolved spontaneously. A few days after, she experienced tremors and palpitations. Upon physical exam, her thyroid is slightly enlarged and tender upon palpation. And this is the result. TSH of 0.19, which is low, and elevated FT4 and FT3. Again, our interpretation is limited to thyrotoxicosis. But with a clinical background, of course, we are suspecting that this is a possible subacute thyroiditis. So for our question, when do you likely expect the thyrotoxic symptoms to disappear? Is it A, 1 to 2 weeks, B, 4 to 6 weeks, C, 10 to 12 weeks, or letter D, 16 months? Subacute thyroiditis usually precedes a low-grade upper respiratory tract infection and may manifest with sore throat and low-grade fever. This is followed by the thyrotoxic phase as represented by the shaded area of low TSH and high FT4 representing the leakage. This will be followed by the hypothyroid phase wherein there's depletion of the circulating FT4 and the thyroid function will need some time to recover. TSH will increase concurrently. A good number of patients recover back to their euthyroid condition. It is important to plot the time interval of signs and symptoms because obviously thyrotoxicosis exceeding 2 to 3 months rules out subacute thyroiditis. It is time to consider other causes of primary hyperthyroidism. So the answer, based on the figure I presented, is after 4 to 6 weeks, the symptoms and the biochemical elevation of your thyroid hormones disappear. She denied intake of thyroid hormone-containing pill, which finding will make you suspect that she has thyrotoxicosis factitia and not subacute thyroiditis. For example, if this patient is actually taking diet pill that contains thyroid hormone, which she may not know. Is it A, low radioiodine uptake, letter B, low TSH, high FT4, letter C, low serum thyroglobulin, or letter D, high ESR? The answer is low serum thyroglobulin. This is actually a board question for those who are taking the PSBIM. Thyrotoxicosis factitia is the only form of thyrotoxicosis, which, of course, we know that there is suppressed TSH and high FT4, but the serum thyroglobulin is decreased. As you know, both thyrotoxicosis factitia and thyroiditis will give you a low radioiodine uptake result, and it will also give you a low TSH and high FT4, both of them. Only high ESR is found only in patients with subacute thyroiditis and not thyrotoxicosis factitia. But low serum thyroglobulin is representative of patients who have thyrotoxicosis factitia because the thyroid gland itself is suppressed. While in thyroiditis, there is leakage of the thyroid hormone and leakage of your thyroglobulin, which is normally inside the thyroid follicles. A good history noting that the patient is taking more than adequate levothyroxine dose will save the patient of this additional test. Sometimes there are unlabeled weight loss pills that do not disclose its content, including levothyroxine. Serum thyroglobulin determination may be of help in these cases. The next case is about a 35-year-old female who presented with infertility. Her gynecologist did a preliminary workup. Except for the slightly elevated TSH, other tests were normal, including FT4 and FT3. Will you give this patient levothyroxine? A, yes, B, no, or letter C, I need further tests. The definition of subclinical hypothyroidism is based on abnormally elevated TSH. Most experts accept the traditional upper limit of normal to be 4.5, but some would argue a lower upper limit of normal of 2.5. Recently, upper limit of normal for TSH may also vary among age groups. Elderly patients above 65 with TSH of 4.5 to 7 is still compatible with physiologic aging. Most patients with subclinical hypothyroidism have TSH of less than 10, and most of them are actually asymptomatic. Repeat serum TSH should be repeated in most after 1 to 3 months, except for pregnant women who needs to have levothyroxine supplementation to improve maternal and fetal outcomes, and also infertility patients in which a repeat TSH and FT4 may be immediately performed and decide on whether there will be benefit for levothyroxine supplementation. The most common differential diagnosis for your subclinical hypothyroidism will be your recovery from non-thyroidal illness or CQ thyroid syndrome, wherein TSH is the first parameter to increase in contrast to FT3, the first parameter to decrease initially at the start of the illness. The next is recovery from thyrotoxic phase of your subacute thyroiditis, wherein TSH elevates because of gradually clearing FT4 after the leakage. Sometimes, you catch them when FT4 is still normal before hypothyroidism ensues, or they do not progress to hypothyroidism at all. Number 3 is assay error, interference, or variability. Rare differential diagnoses are central hypothyroidism with low normal FT4. About 25% of them presents with mildly elevated but defective TSH. Morbid obesity because of leptin hypersecretion and resistance increases your TSH as well. In our patient who is seeking infertility management, it may be prudent to repeat TSH and concurrent FT4 at once and decide on whether to manage the patient. Anti-PPO antibody positivity will also favor initiation of therapy in this patient. The most important determinants of progression hypothyroidism is the level of TSH. Patients with TSH more than 8 or more than 10 in some literature are the ones who are likely to progress to hypothyroidism. And the presence of anti-TPO antibody, which is the hallmark of Hashimoto's disease, is also a risk factor for progression to clinical hypothyroidism. The next case is a 65-year-old male who presents with irregular heartbeats. He consulted a cardiologist and workup showed atrial fibrillation. TSH is 0.15, which is suppressed. FT4 and FT3 are normal. Will you give this patient antithyroid medication like metimazole? Letter A, yes. Letter B, no. Or letter C, I need further tests. In a patient with suppressed TSH, it is important to ascertain the diagnosis of subclinical hyperthyroidism and the degree of its suppression. It is recommended to repeat the test after 1 to 3 months before labeling subclinical hyperthyroidism, because giving antithyroid medication may produce greater harm than the benefit if given in subset of patients with potentially erroneous result or transient TSH suppression. Most patients with TSH more than 0.1 have transient low TSH only. A positive thyroid uptake and/or scan will support the decision to give antithyroid medication. A thyroid ultrasound will also be helpful if a nodule is palpably present or appreciated in the thyroid scan. Common causes to consider are recovery from thyrotoxicosis or initiation of antithyroid drug like metimazole. Remember, it takes TSH more time, even months, to normalize as opposed to FT4. Pregnancy is also a common differential. Pregnancy can suppress TSH, especially in the first trimester, wherein HCG imparts TSH activity. Over-replacement or iatrogenic levothyroxine with recent discontinuation can suppress TSH, while FT4 is already back to normal. Rare causes are central hypothyroidism with a dysfunctionally high TSH and a low normal FT4. And also severe non-thyroidal illness with low normal FT4 and of course unchecked FT3. In this patient, repeat TSH is still suppressed at 0.09. FT4 and FT3 are still normal. The 2D echo revealed no valvular abnormality, and the thyroid uptake is slightly increased. Given the degree of low TSH, which is less than 0.1, increased uptake, and CV risk, this patient is a candidate for metimazole treatment. For our next case, this is a 28-year-old female, 16 weeks pregnant, referred by an obstetrician. The OB finds her thyroid to be slightly enlarged, so she requested for the thyroid function test. TSH is a little bit low, while FT4 and FT3 are all normal, which is an expected change in this pregnant patient. Increase in thyroid gland by 18%, increase in TBG because of estrogen, increase in stimulation of TSH receptor by your HCG or human chorionic gonadotropin, or letter D, all of the above. Increase in thyroid gland is expected in some pregnant patients, but the increase is very mild that usually it is not noticeable. What is most striking is the increase in your thyroxine binding globulin by the estrogen hormone. Aside from increasing the absolute value, it also increases the sialylation of this thyroxine binding globulin. Sialylated TBG can bind thyroid hormone more than its non-sialylated counterpart. Of course, during the first trimester of pregnancy, peaking at the 10th week, there is an increase in your HCG and a concurrent suppression of your TSH. So the answer for our question is all of the above. For our next case, there's a 56-year-old male admitted in the ICU because of acute respiratory failure. On the 5th hospital day, he had episode of hypotension and supraventricular tachycardia. TFTs were also requested. As you can see here, TSH is normal, FT4 is normal, but your FT3 is low. This is isolated low T3. And in the setting of moderate to severe illness, we call this non-thyroidal illness or CQ thyroid syndrome. Observe the graph. T3 falls ahead of TSH and T4. T3 is represented by the black line, and your TSH is represented by the dashed line, black dashed line, and your T4 is represented by your blue solid line. Your reverse T3, which is not available commercially, only in research setting, increases in an opposite direction with your T3. Low T4 is a more severe form of non-thyroidal illness and is reflective of a very poor prognosis. After recovery, which is not shown in this graph, TSH is the first parameter to improve, even exceeding normal, pulling up T4 and T3 until complete recovery of the patient. On the 7th hospital day of the same patient, the patient deteriorated and dopamine drip was started because of hypotension from septic shock. The TSH, FT3, and FT4 was repeated by the resident, and it showed low levels of all the three parameters. This TFT shows that your LT4 becomes low as well, aside from your FT3. And this suggests a severe non-thyroidal illness, while your low TSH is either due to the severe NTI as well, or more commonly, because of the ICU medications, in this case, the high-dose dopamine drip. For our last case, a 28-year-old male presented with bilateral hemianopsia because a non-functioning pituitary adenoma was also found in the MRI. The size of the adenoma is 4 by 3 by 2.5 centimeters. He presented with low cortisol and free T4 level. But as you can see, the TSH is within the normal range. Which is an expected TSH in central hypothyroidism? Is it A, high TSH level, B, normal TSH level, letter C, low TSH level, or letter D, any of the above? Before we answer that, I need to tell you that we cannot rely on TSH in the diagnosis of central hypothyroidism, whether low, normal, or high TSH in the setting of central hypothyroidism, such as in pituitary or other cellular tumors, coupled with low FT4 more than low FT3. This is already a reason to call for the diagnosis of central hypothyroidism. Because although produced in small or normal or even high amount, TSH in central hypothyroidism has low bioactivity. And this is because of the non-sulfation of the important peptide moiety of this TSH glycoform. In physiology, sulfation and glycosylation increases the TSH activity of the normal TSH. And this is absent in the TSH of patients with central hypothyroidism. So the answer is that any level of TSH, as long as there's a clinical setting and low FT4 especially, you can call for the diagnosis of central hypothyroidism and start with low-dose levothyroxine therapy. That's it for the clinical cases. For the summary and key points, I will go on live and entertain some of your questions as well.
You may now proceed to our Sunset Symposia. Please go to www.tiktok2021.com and click on the room you would like to join.